Hello, my name is Eran. I'm delighted to be here really representing Saben Nsanzimana, who couldn't come to the meeting in the Rwanda Biomedical Center. I'm going to try to represent the perspective of Rwanda on implementation with as much fidelity as I can. As a brief overview of the HIV epidemic in Rwanda and the HIV response in Rwanda, the first cases were identified in the early 80s, and there was an early national AIDS program that was established in 1987, well before the genocide. The genocide, of course, happened in 1994 and had entirely destroyed the nascent HIV program. Subsequent to the genocide, there was had started a prolonged period of rebuilding the national health system with a remarkable commitment to the Ministry of Health and from the Ministry of Health for HIV, and that has been an important, a critical factor for the kinds of experience that I will discuss in the next few minutes. Today, the ART coverage is about 79% of, actually this is no longer updated. It's no longer, the guidelines are no longer CD4 less than 500. It's now ART for all as of a couple of weeks ago. They have experienced a 50% decline in the rate of new infections identified year on year. And the number of deaths has declined by 78% from a peak in 2010. The rate of mother-to-child transmission is about 1.8%, and estimates of demographic estimates suggest that life expectancy for people who live with HIV/AIDS is now 25.6 years longer than it was in the pre-ART era. Rwanda has an extraordinarily integrated system of HIV services. You can see here of the nearly 600 sites that provide either testing, PMT-CT, or ART. The majority of them are co-located, where you have the testing and the PMT-CT and the ART in the exact same location, and the distribution throughout the country. Rwanda is not a very large country, several hundred kilometers across, is really quite dense. National HIV guidelines have meandered here and there. As we all know, it's not an easy task to get things right, and the WHO guidelines and financial constraints have led to multiple changes. In the most recent iteration in 2013, Rwanda has moved to treating everybody with a CD4 less than 500, and then as of 2016, early July, they had decided to move to a treat all for anyone who is identified with HIV. Like many of the trials that we've heard about before, there is here, as a matter of national policy, there's a strong commitment to actually providing the treatments. And this is Rwanda, one of the advantages of having a centralized and highly integrated public system is that there's actually a lot of very good data. And so among they actually have information on all the people in the various healthcare, in the various parts of the healthcare system with HIV. And so among all those who are infected, estimated through DHS national surveys, about 86% have been diagnosed. Among those, about 93% have established care. Among those, 79% have initiated ART by now. And among those, 86% of those who have initiated ART have undetectable viral load. And you can see the numbers that are required in order to reach the 90-90-90 goals. Relative to other countries and relative to relative to national income, you can see that Rwanda is really among the top performers in terms of having their pretty high proportion of all people with HIV on ART. sort of nestled there between the Netherlands and Denmark. And certainly when you look at the UNAIDS target, it is not very far off, even on a national scale. Rwanda's GDP per capita is less than $700 in 2014, quite a bit from off from its neighbors. Again, the national commitment has been really important for this. Incidence has continued to decline, in fact continues to decline and projected to continue to decline with their current rate of scale up. Unlike some of the estimates of the global HIV epidemic, despite stable prevalence, the estimates for incidence is expected to continue declining. Okay, in some words of conclusion, ART scale-up really continues at a pretty vigorous clip. HIV prevalence has stabilized. It has remained at 3% over the past several years, mostly because of improved survival. And incidence continues to decline with ART scale-up, but there are several important features that deserve mention. UNAIDS estimates suggest that incidence in Rwanda is about 0.1 per 100 person years. So when you look at empirical estimates of incidence, they're more than twice that. So there's underscoring the need for continued scale-up of treatment and prevention. Young adults and singles are at greatest risk of new infection, and there's a fair bit of geographical variability, really suggesting some opportunities for targeting by location. Some implementation highlights. The highly integrated HIV care system really helps both with monitoring and the design of services. You know where people are. You know where are the people that you need to reach throughout the entire country. Successful public health system caring for nearly all those with HIV, again, allows you to have very comprehensive care. There's a very strong national commitment that has translated to very high ART coverage, but the challenge is that sustaining the gains with limited and declining resources is a challenge, especially in the face of the desire and the need for new and increasingly expensive medications. Retention of patients in care and long-term management of resistance to ART has been a challenge. And the community involvement to understand the risks and benefits of diagnosis and immediate treatment. So the generation of demand for ART is an ongoing challenge. And with this, I will pause.